All right, chapter 9 is kind of a short chapter um, just on joints. A lot of this, again, just like chapter 8, really is something more for the lab. But I'm going to go over some of the categories here. It's a little confusing, to be honest, especially as a student, to look at this, to understand what's going on. So I'm going to try and orient you with this. And then there's a bunch of joints according to the learning outcomes for the course that you're supposed to be familiar with. I've got some materials here to help with that. But as I will say later, the main thing to know, like in terms of for the tests and your study guide materials, I would focus on the study guide. So I'll get to that in a sec. So, all right, so here are the learning outcomes for chapter 9. They're pretty straightforward, very standard. But as always, as I found with the learning outcomes with this course, is that there's some vague parts to it. So like for me, number 8, describe the major anatomical features of the jaw, shoulder, elbow, hip, knee, and ankle joints. It's kind of hard for you to know as a student what's the major features. So I'll try to point out a few things, and then, like I said, and I will harp on again, focus on the study guide because I make that guide while I'm making the test, okay? Yeah, here, and explain how the anatomical differences between these joints are related to differences in function, all right? So I'll try to just give you a few ideas when we get there, and I'll spend most of the video talking about this stuff up here, okay? All right, so when it comes to joints, understand that their proper term is articulations. And I found this picture on the internet, and I kind of included it because I thought it was a good summary. And then there's going to be another summary after I walk you through all these ideas, all right? So basically, and of course my last slide won't be as pretty as this, but anyways, here you can see that joints or articulations are classified in 2 ways. One is their functional, one is by their function, and the other is by their structure, all right? So when it comes to function, it has to do with how freely the joints move, all right? And here are the names. I'm gonna go over these. These are hard to say, even I can't say these. Diarthrosis, amphiarthrosis or amphiarthrosis, and the synarthrosis, all right? And basically, you can see here the diathrosis, this one here, diathrosis, or if you're talking about one joint, diathrosis is freely moving. The next one is slightly movable, and the last one, little or no movement. All right. So, but in order to understand this part, it's best to understand their structure. So I'm going to start with the structure. All right. And there's 4 different classifications in terms of their structure. So fibrous, cartilaginous, bony, and synovial, all right? And a lot of these make sense just by looking at their names, cartilaginous and bony, right? So I'm gonna walk you through those and then use this to explain the functional aspect and how freely they move, all right? And how they're classified in that way. And you notice that there's 4 different structural classifications and only 3 functional, all right? So and these names get very confusing, all right? And I know this, so hopefully the materials here will help orient you as well as the notes that I've put together, all right? So when it comes to the types of joints, and I'm gonna go through all of these ideas, but this is their summary slide, all right? So when you're talking about their structural classes, all right? We have bony, fibrous, cartilaginous, and synovial. In bony, and there's another term for bony, just to make this even more confusing, is synostosis, all right? And this is when bones become fused into one, right? So you have to start off with 2 bones and they get fused into one. And one of the examples is the epiphyseal plate. Oh, I can't talk, it's too early and it's cold outside. So epiphyseal plate, all right? So, you know, after maturity, as we discussed in the previous chapters on bone, is that the plate gets fused into a line at maturity. So this would be a bony joint, okay? And it's basically stays as one bone after that. Fibrous joints come in 3 different flavors: sutures, the syndesmosis, and the gomphosis. I didn't take Latin, so, but anyways, this is how it's spelled. All right, sutures, you know what those are, right? Those are the joints between your most of your skull bones, right? So no movement, but they're fibrous. They're not bony, which might surprise you, okay? Then we have these ones are dense fibers. So these ones are short, dense fibers. These are longer, dense fibers. And this would be like those membranes between the radius and the ulna. And this one here is very special because it just refers to your tooth socket, so where your tooth is attached to your jaw, all right? So these are all fibrous. And then we have cartilaginous, which also come in 2 different flavors, all right? The synchondrosis, and these are made up of hyaline cartilage, right? And here's your epiphyseal plate. This is before it becomes a bony joint, all right? So here you've got hyaline cartilage as we went over. And then the other ones are the symphysis. These are fibrocartilage, all right? So like your pubic symphysis, okay? So those are the differences there. And then the last one is synovial, which I'll spend the most time on. These are what most people think of when they think of a joint. These are the ones that are freely movable. Okay, so here, and there's a number of different types and a number of different types of movement. And we will all have special slides just for those ideas, all right? So let's go through this. So bony joint, right? And here's the other term for that here in red, synostosis. Here, this is where you have an immobile joint that is formed when the gap between 2 bones ossifies and the bones become, in effect, a single bone, all right? And the best way of imagining that would be the epiphyseal plate becoming the epiphyseal line, all right? So this is in the knee here, so you can sort of see this example. And they are a fused bone and they're fully ossified, okay? And now these bones, these bony joints, they can start off as either a fibrous or a cartilaginous joint, right? So you know that this is a cartilaginous joint to start off, right? And then it becomes ossified and it becomes a bony joint, all right? Now the fibrous joints, so remember there are different types, okay? So here the adjacent bones are bound by collagen fibers, all right, that are gonna emerge from one bone and penetrate into the next. And we have the 3 different types: sutures, syndesmosis, and gomphosis, all right? And I'm gonna have a different slide for each one. So sutures, all right? So these are immobile or very, very slightly mobile, especially depending on your age, right? So you've got short collagen fibers that are gonna hold these things together, and these are your skull bones, so you should already have learned your sutures. Now, the interesting thing here that I didn't know, this wasn't something new I learned this year, is that they're classified by the way those bones, those skull bones, interact with each other and how that they are fused by that collagen. So we have 3 different flavors. We have serrate, lap, and plain, okay? And then here you can see which ones are which, and I'm gonna show you pictures of each type. But basically the serrate, you think of them as serrated, right? So that would be an interlocking, like, you know, a serrated knife has those little lumps on it, right? So those are the ones you use for cutting bread, right? Or tomatoes. So interlocking wavy lines. So that would be like your coronal suture, your sagittal, and your lambdoid sutures. Lap, this is like an overlapping or a beveled edge, all right? And this would be the temporal and parietal bones are linked that way. And then we have plain or butt. Sometimes they're called butt. So here's one here. Also, lap is also called squamous. Plain or butt, right? These ones are straight on, non-overlapping edges. So that would be like the palatine processes of the maxillae, right? So remember, in the baby or in an infant, the maxillae are 2 separate bones, and then they fuse, all right? So they become a suture, right? So they're fused with this immobile cartilage there, right? And if they don't fuse properly, then you have children with cleft palate and that kind of thing, right? So, so here, if you look at the different, right? So here is the serrate, right? So it would be like if you're into woodworking, that dovetail joint. So they're sort of overlapping and they sort of intermesh with each other, all right? So that would be serrated. And then the lap, right? So it's interesting that they're aligning it. My father was a carpenter, so I'm familiar with the way these joints look. But here's a miter joint, right? If you're a carpenter, so it overlaps like this, and then a butt joint or butte, or however butte would have an E on the end, so it is a butt, or a plane joint. So it would be flat against each other. All right, so those are the differences, and you can see which bones are put together that way. And like I said, this was something new to me. I thought they were all like this. I didn't realize this. So this is something, like I said, I'm always learning something new about the body, and it's always fun to come up with something different. And this is actually the first textbook that I've seen do this. This is the Saladin text. I've never seen this before, so this is actually kind of cool. All right. Now, the next one is the syndesmosis. And this one is where you have a fibrous joint, but now we've got long collagen fibers. And the best one example are those interosseous membranes between the tibia and the fibula, as well as the radius and the ulna. So those would be really great. So these have a little bit more movement, right? So the one between the radius and the ulna is a lot more mobile than the one between the tibia and the fibula, all right? But in general, we don't really think of these as being motile bones, as you'll see when we get a little bit further. But there is a bit of give here, all right? And then the gomphosis, right? So this is, when you're talking about this one, we're talking about these, specifically the tooth and how it's placed into the socket. And there's collagen fibers that hold it there, all right? And so it's the attachment of the tooth to the jaw with these collagen fibers. And they give this a special name as a fibrous joint. And you don't really think of your teeth as being mobile until something happens, right? So if you bump a tooth and it gets a little wiggly, and sometimes you might lose it if you're really unfortunate because you've torn these fibers, all right? But in general, you don't think of your teeth as being able to move around. Okay, especially as an adult, right? Now, the cartilaginous, so that comes in the two different types. So cartilaginous joint is also called an amphiarthrosis, right? And as you'll see, this is also the functional classification, all right? So, but I'll bring that up again later. So sometimes the cartilaginous joint is synonymous with this term, which is also its functional classification. So, which doesn't help when you're trying to learn this, all right? So for here, when I talk about cartilaginous joints, we're talking about these two different types, the synchondroses and the symphysis. And remember, always when you see chondro, you know you're talking about cartilage. So I had spoken about that before, all right? Now, so what are our examples? Right, so we have the ones, the synchondroses. These are bound by hyaline cartilage. So temporary joints of the epiphyseal plates in children, right? So we've already gone over that. But this one here is something else new. I didn't know that the first rib attachment was like this. I didn't know that that was hyaline cartilage here. So the first rib attachment. All the other ones are synovial joints, which we'll talk about later. But this first one is actually a cartilaginous joint. I did not know that. So that was something else that was new for me this year. I'm learning all kinds of new stuff this year, which is great. So I would just think, oh, well, cartilaginous joint, but hyaline cartilage, and I always just thought about this one, and I did not know about this first rib attachment. So that one would be, so rib one, that is a cartilaginous joint where you actually have hyaline cartilage, all right? So that one was really cool. And then the symphyses, these ones are, for me, I always easy to remember. So here you're dealing with discs of fibrocartilage. Right away you think of intervertebral discs. The other one would be the pubic symphysis, which is why it has that name, pubic symphysis, because it is a joint that is a symphysis, one of your symphyses, all right? And this one would be, like I said, fibrocartilage as opposed to the hyaline cartilage of the other joints that are cartilaginous, okay? And again, the cartilaginous joints have very little or some movement, like minimal movement in general. Obviously, your intervertebral discs have more movement than your pubic symphysis. Pubic symphysis has more movement if you're a woman who's going to give birth, because there's a hormone that's produced, relaxin, that sort of loosens that up and makes birth a little easier. Now, the synovial joints. So this is the fourth structural class. And these, like I said, are the ones that most people think of in terms of, when they think of joints, all right? And these are very special joints, and there's many different classes of them depending on the type of movement that they allow, all right? So this is a joint where two bones are separated by a joint cavity, and that joint cavity is filled with synovial fluid, all right? And since they are movable joints, there's a whole set of support structures that maintain that. Why? Well, because these are the ones that are most likely to suffer some sort of dysfunction, all right? And their mobility, like I put down here, really important to quality of life, all right? And I'm sure that's, the mobility that they allow varies with age, all right? And as you get older, they get stiffer for a lot of reasons, all right? So if you look at my notes, I have a whole bunch of different ideas. Fluid-filled complex joints. There's a synovial membrane that's producing synovial fluid. But there's also, so that would be your inner membrane, but there's an outer membrane of fibrous, dense, irregular connective tissue. So remember, irregular connective tissue allows for stretching in different directions. But since it's dense, it's strong, okay? So that sort of is there for support. And then, of course, you have your ligaments involved with that. So your ligaments would be joining your bone to bone. Tendons can also be involved in the joint, as you'll see in the more complicated ones between bone and muscle, all right? And then you have structures like bursae, which are fluid-filled sacs, cartilaginous fluid-filled sacs. There's actually synovial fluid inside of them to really cushion and reduce friction. And menisci, which are pads of fibrocartilage to increase strength and provide a better fit between the movable bones. The other really important thing is that the bones that are in that joint, they're they have on their ends, they're not coated with it, hyaline cartilage. So hyaline cartilage connected, continuous with the bone in those joints. So remember, the hyaline cartilage is that nice glassy cartilage that makes things smooth. And I might have mentioned that if this gets damaged, because hyaline cartilage is, you're kind of born with that. You can't just make it. So if it gets damaged in these joints, it's going to be replaced by fibrocartilage, which isn't as smooth, all right? So your joint will never be the same again, all right? Depending on the amount of damage, all right? But synovial joints, we've got all over the place, where you think of moving bones, all right? Or movable joints. These are all synovial joints. They're all over the place, all right? Okay. So here, let's go look through the slides. So I went over the notes. So let's go over the slides to highlight those differences, right? So here I'm showing you, how these bones fit into each other, right? We'll find out this is called a ball and socket, but you can see how nicely this bone fits into the other one here. This is the femur, and this is the os coxa. So you can sort of see this nice thing. Now, if this is from a cadaver, but there would be a wonderful layer of hyaline cartilage here in between these two joints, within this joint, between these two bones. And since that cartilage is found in an articulation, very often that particular hyaline cartilage in those articulations is called articular cartilage. So if you see articular cartilage, know that it is hyaline cartilage, all right? Now, I mentioned it to you that we've got the two layers surrounding these joints. So there's the outer fibrous capsule. This is, like I wrote down, it's dense, irregular connective tissue. Notice here that it's continuous with the periosteum, right? Just like the ligaments are, right? So this fibrous capsule is continuous with the connective tissue on the outside of the bones. Then the inner layer is composed of the cells that produce synovial fluid, right? So they look sort of like fibroblasts if you look at them under the microscope. And there's also macrophages there that will help clear out debris. And that's needed because there's going to be movement there and injury, and there's no blood supply here, which is why it's really hard for joints to heal, all right? So the macrophages are going to get rid of whatever gets in there. Now, the synovial fluid itself that's being produced by those cells, it's, as you might imagine, it's slippery. And the reason it's slippery is because of the type of proteins that are there. So there's albumin there, and if you later on when you learn about proteins in the blood, albumin is one of them, and hyaluronic acid. And if you're someone who follows skin products, I don't actually, but I know this because I know what hyaluronic acid is, but very often they'll talk about creams, anti-aging creams have hyaluronic acid in them. It's a type of protein. You can see there's acid groups on it. This synovial fluid, in addition to providing this nice surface and joint, you can almost think of it like oil in a joint, right? It also is nourishing the cartilage, all right? And it makes this almost friction-free, this movement that you have here, all right? Then we could have, like I said, discs. These are going to be made up of fibrocartilage that forms a pad between them. And a really good example is between the femur and the tibia. Here's a meniscus. I don't know what kind of image this is. I don't know if it's an x-ray or what it is, but you can really see how this meniscus is really helping the form between the femur and the tibia. That's what we have here. And these articular discs form, these pads between different bones, all right? So that would be, articular discs, again, would be like those that you have between your vertebrae, right? So there's, that would be an example, even that's not a synovial joint, but you can also get little pads that are forming between these bones that allow for some sort of support, okay? So these cartilages are going to absorb shock and pressure. They're going to guide bones past each other, stabilize the joint, and reduce the chance of dislocation, all right? So just to sort of help that. And of course, these synovial joints are easily dislocated, depending on how they're structured. Then, of course, we have tendons. Tendons, of course, are connecting muscle to bone, but they will go over a joint and they can help, provide support, okay? And you can see here a tendon sheath. You get tendons here that are going to be running between the muscles and the bones, but they're going to be running over the joint. So they're providing extra support. And of course, ligaments between bones, all right? They obviously will also be doing this. And these here, these tendon sheaths. So these are like these, okay, this is kind of weird. So there's these bursa, which are fibrous sacs. They're filled with synovial fluid, and they're going to be providing extra sort of cushioning where you have a lot of different types of movement. So there's a lot in the shoulder, as you'll see. And then the tendon sheath are elongated bursa, right? And they're going to be covering different things. Like you can see them a lot in the hand and the foot. So these are all support structures for these synovial joints, all right? So here's some examples. So here, synovial membrane. This is just a diagram, but there's an inner synovial membrane and then the outer fibrous membrane, right? So you can imagine now how that's sort of structured in the joint. Here's your articular cartilage in between them, and here's your really viscous, slippery fluid, the synovial fluid. And then here on the knee joint, you can see a whole bunch of menisci, right? And you'll have to, these are, we do this in lab, but the lateral and the medial, so you know which side of the body they're on. And they're sitting here on the top of the tibia. Once you start looking at the tibia in lab, you'll see it's sort of very flat-ish on the top. So these menisci are going to be helping with that, right? So you've got these cartilaginous pads, all right? And the ones that are called menisci have this very sort of moon shape. So if If you go back here, I said articular discs and the meniscus. You know, how are they different? Well, the meniscus are special. They're given because they have that moon shape, right? But the articular discs are going to be doing a very similar thing, but they don't tend to have that moon shape, right? So it's kind of weird, but they're sort of the same. They're pads of cartilage, all right? Now, other things that you can see here, if you look at the knee joint, you can see some ligaments that are connecting here. You can see that there's some ligaments that are going right through the joint, right? So here's the posterior cruciate ligament. Here's your ACL, the anterior cruciate ligament, which is why if this is torn, it takes a long time for it to heal because it's actually right through the joint, right? And then you have other ligaments that aren't going through the joint. So this is, of course, is the knee. So here's your tibial collateral ligament. This one is going over, right? So it's attaching, the tibia, and it's staying on the outside over to the femur, all right? And then, of course, there's the patellar ligament. You know, there's your patella for your knee. This is going to be on the anterior side of the body. It's not in the joint, but it is obviously a ligament that is supporting that, okay? And then when it comes to these bursae, there's a lot in the shoulder, all right? So there's a lot. So if you look here, this is why shoulders get dislocated so easily if you get pressure from above, right? Because there isn't a lot of bone here supporting it. But notice there's a bursa here, another one here, and another one here. This is all supporting this, right? So actually I have different slides that highlight this. So there's your medial and your lateral meniscus, and then down here, your subscapular bursa. So this is your scapula underneath here, provides support, all right? Now the point of this slide is to highlight these articular cartilages. And remember, it's hyaline cartilage. This should remind you very much of when we were talking about the formation of bone from cartilage. This is continuous with the bone, which is why I love this image. So you can really see that developmentally, this was laid down during development and on the way to maturity to be contiguous with the bone. And you can imagine now if this gets damaged, there's no real way of repairing it. So you just get a bunch of scar tissue or scar cartilage, which would be your fibrocartilage. It's just not gonna come back as hyaline cartilage, all right? So this is, remember it's called articular cartilage, this particular hyaline cartilage, because it's found in these joints or these articulations. And then here, as I was highlighting before, that these ligaments can blend with each other and go through the joint or go outside the joint, so that you can sort of see that there's, the ligaments, I mean, there's no really rules to say that all ligaments have to be outside the joint or all ligaments are inside the joint. It will depend, right? And the knee is really a good example of that. And this is usually why knee is highlighted in lab, right? We've got models of that. Every anatomy lab has models of the knee, and every anatomy student learns all of these different parts, all right? So these are ones that, and I'll highlight this later, that the knee joint is one that is always a highlight in AMP. So this is the one where I've got a lot of pictures of this. Now, remember, there's the structural classifications and the functional classifications. So here are your functional classifications, all right? So they go from, like I had said earlier, in terms of the type of movement. So from no movement to most movement. So of course, you've got the most movement with the synovial joint. So all of the synovial joints, in terms of their structural class, their functional class is called the diarthrosis. And very often this term will also be synonymous. And I sort of put this on, if you look on page 3 of my notes, if you see the term diarthrosis, it automatically means synovial joint. All right, so this is why it gets confusing, but this is the functional classification, and the structural classification is synovial. And I also said to you when I was talking about the cartilaginous joints, very often you'll just see the term cartilaginous, and you can also just see it as the amphiarthrosis, right? So, but understand that this term here is referring to their functionality. So that means that there is some movement, all right? And then the synarthrosis, those are the joints that have no movement or next to no movement, all right? And obviously bony joints would be in here. The other ones that are here are fibrous joints, all right? So sometimes when you see this in a book, you'll see synarthrosis and it will just say fibrous, and they'll completely forget about bony. But bony is also, has no movement, all right? Or almost no movement, as you saw that, you know, some of the fibrous joints have a little bit of give depending on context, all right? Which doesn't make it easier to learn, but hopefully that makes some sense to you. Now, things that could go wrong, so arthritis, and there's different types. So when it comes to rheumatoid arthritis, you can get this pretty much at any age. It's an autoimmune situation. So you have antibodies that are being raised by your body against your synovial membranes. And many joints are going to be affected by this, all right? So here with rheumatoid arthritis, you basically have a state of inflammation in the joint, and it's painful and swelling. And again, this is not, does not have to be an arthritis of age. I have a friend who's 10 years younger than me, and she's been, as long as I've known her almost, she's been having problems with this. So I met her when I was in my 20s, all right? She helped me with my wedding. I got married when I was 29, right? So she was, you know, just turning 20, and shortly after that, she started to get rheumatoid arthritis. So, and then the other one would be osteoarthritis, which is the one that we normally think of with aging, but any type of joint that is suffering a lot of wear and tear. So if you're an athlete that is really stressing certain joints, you can get osteoarthritis younger than, you know, than you would normally think of as an older person, right? And that would cause deformations of those joints. And what's happening there is really literally wear and tear. So the synovial fluid is drying out, the bones are starting to rub against each other, and it's just an aging joint or a well-used joint. And this does not appear all over the body. It would be those joints that are particularly used, right? So that's why it's in the hands very often. You see that with older people in the hands. My mother now, she has, I'm seeing the inflammation in certain joints of hers, and she's getting some of these deformations, all right? And this increases with age. And I don't actually know if there's anything you can do about it other than just not moving, right? Which is not possible. So this is why this happens as you get older. The other kind of arthritis you might not be thinking of is the gouty arthritis. This again can happen at any age. This is usually due to some sort of problem with protein metabolism. And a byproduct of protein metabolism is uric acid, and it tends to crystallize out in your extreme joints. So in your hands, and it's known by the big toe kind of thing. And this is, you know, inflammation and why you're having the protein metabolism problems. You know, would be something for a medical doctor to help the patient with. But this is, you know, a different type of arthritis, and it's affecting, again, the synovial joints in the extremities, all right? Now, what is done? Arthroplasty, so basically what they do, and I know this looks really gruesome, and it to be honest, this freaks me out too. I can see a lot of stuff, but this stuff, wow. But it's very common. So when they replace a hip or a knee, they're replacing it with prosthesis. So there's going to be metal and Teflon here that's going to replace the damaged bones. And like, you know, a lot of older people get their hips done or their knees done, and this is what's done. And so they actually get rid of the bone and then they fuse in a replacement or an artificial joint to and yeah, it looks really gruesome, but yeah, this is what they do. But it really helps with quality of life, and it's good that we can do this now, even though it does look pretty scary. But yeah, so that's very important that we can do that. Now, let's talk about these synovial joints. So the synovial joints are classified by how the bones articulate, as well as the type of movement, all right? So this gets really overwhelming, all right? And I know this, right? So first of all, let's just go over the types of joints. And this is a summary slide. I have slides for each type. to help you imagine them, all right? So we have plane joints, hinge joints, pivot joints, condylar joints, saddle joints, and ball and socket. And to be really honest with you, I find condylar and saddle really hard to differentiate. And it really comes down to the shape of the joint, right? So if you say saddle joint, you think of somebody sitting on a saddle, all right? Literally, right? So here would be the legs and here's the saddle. And then a condylar joint was sort of looks like sort of like a cup with a ball inside it, right? Not to be confused with the ball and socket, all right? So that one is literally a ball in a socket, all right? But here it looks sort of like a facet, like sort of a groove with a curve in it, all right? So it's kind of, it's different. So, you know, this, I like this picture because it kind of lets you really see it. And then the other one, the hinge joint is like, you know, the door hinge. A plane joint, literally bones flat against each other, and pivot is just some sort of rotational type of idea, all right? Now, you're going to see this terms uniaxial or non-axial or multi-axial. Sometimes this is usually, you know, monoaxial, but anyways, that is referring to the directionality of the movement. So if you want movement in one plane versus two planes versus no planes, or many planes, so it'd be like non or mono or uni, right? Sometimes it would be mono and uni, or bi would be two directions, and multi would be many. All right, just so that we can sort of orient ourselves. So right, so here a planar joint, articulating surface is flat or slightly curved. Okay, and I wrote down in the notes biaxial, all right, because I saw that in your textbook, all right, which is weird because here it says the plane joint is non-axial, all right, so very, very weird, but I'm just highlighting that here in my video because I know that that's a discrepancy, and I don't have any explanation for it, all right. And I think it comes from this, because you have back and forth and side to side movement. How much movement you have? Probably very little, all right? So that's how I would explain this non-axial, because you don't usually want to think of your carpals moving around, all right? Or your tarsals. So I think that that's where it comes from, but understand that there's a little bit of give there, because you don't want to damage your foot, all right? So that's the only way I can sort of explain that. But since we're using the Saladin text, go with the biaxial, all right? And biaxial because back and forth and side to side, all right? Now the hinge joint is pretty obvious. Your two hinge joints should right away come to your head, so into your mind, I should say. So your knee and your elbow, right? So here you've got a convex surface fitting into the concave surface of another one. This is monoaxial, right? So you've got one plane, just like a door, it's not going to go any other way, all right? And in your elbow, of course, you've got the olecranon process that's going to actually jam up onto the humerus and prevent it from continuing its movement, all right? So this is really quite restrictive, even though it's a good movement, all right? So it's uniaxial. Now, pivot joints, so this is where you got your pivoting, right? And even though I know it sounds weird, but you're turning, it's called uniaxial because you can't go in any other direction, so you're pivoting, all right? So a pivot joint would be monoaxial. So the rounded surface of one bone is articulating, you know, with a ring structure formed by another bone, all right? So that's what you see here between the radius and the ulna at the very top, right? In the radial notch in the head of the radius. So the radial notch, remember, is on the ulna, and the head of the radius is obviously on the radius, all right? And there's a ligament there. It's called the annular ligament. And if you know what an annulus is, it's always a circle, right? So that should help with that concept. Now, as I said, condyloid and saddle to me are weird, but remember condyloid, it's not like a ball in a socket, it's like a projection that fits into the depression of another bone, right? So it's not as pronounced as like you would see with the ball and socket. It's much more restricted in terms of its movement than a ball and socket, so we see it's biaxial. So movement in two axes. Then saddle joint, it really has to do with the shape. So if you could imagine a saddle with a person sitting on it, right? So you can see very specific. So the trapezium and the metacarpal of the thumb, that would be a saddle joint, all right? So the articular surface on one bone is saddle shaped, and then you have yeah, a little bit more range of motion possibly, but they still say biaxial. But sometimes you can have a bit more modification, a bit more movement depending. But let's, you know, for argument's sake, go with biaxial. And then ball and socket, these are the most freely movable joints, also the ones that are easily damaged. So you know, the head of the femur fitting in the acetobulum of the os coxa is the one example. And of course, the shoulder joint, the head of the humerus fitting into the glenoid cavity that's produced by the scapula and the clavicle, all right? So one bone fits into a cup-like depression on the other. It has the most movement of any other type. So the shoulder joint is also a ball and socket, and here you can see the hip, all right? Now, so this is my much less beautiful summary situation here. So here, by functional classification, structural classification, and then class, right? So the synarthroses, remember, no movement or almost none. Here you're going to have your bony joints and your fibrous joints. And remember, you've got 3 different classes of fibrous joints. Then you have your amphiarthrosis, so you've got some movement. Here you have your cartilaginous joints, and here you have your different types. And then your diarthrosis are your synovial joints, and here you've got your 6 different classes. Now, the range of motion, all right, so what that is referring to is literally the number of degrees through which a joint can move, all right? And if you're someone who enters that kind of a clinic, you're going to assess the range of motion of your patient by the number of degrees of movement that joint allows, all right? So that's sort of what these really weird images allow. So there's a range of motion that would be normal, and then what would be happening with the patient. And on my notes on page 5, I have a list of things that can affect range of motion, and I'm just going to mention them. I don't have slides for all of them. All right, so obviously the structure or the shape of the articulating bones is going to have a huge role to play on that, right? So, you know, whether you're dealing with a ball and socket joint or whether you're dealing with a hinge joint, all right, it's going to really have something to do there. The other thing is the strength or the tension of the associated muscles and ligaments, right? I mean, if that joint is really jammed in there, there's going to have less movement, right? And if you move it too much, you're going to tear the ligament or tear the tendon, right? The arrangement of the muscles there, right? So, you know, flexion and extension pairs, which I'm going to get into shortly. Contact with soft parts. Here, we're not just talking about bursae and menisci or discs. We're also talking about things that shouldn't be there, like scar tissue or adipose tissue that might be built up around a joint. And that's going to affect that, right? I know when I was pregnant, for example, all of a sudden I couldn't bend over enough to see my feet. So there was a soft thing in the way, which was my daughter. I know that might sound funny, but when you're in that situation, you're like, all of a sudden I can't bend over enough. That was temporary, and for me, much more temporary than others, because you might not realize this, but my daughter was born 3 months early. And so a lot of the reason I couldn't bend over was because my body gained water like nobody's business. So it really wasn't her. It was all the liquid and the fluid that ended up being in my midriff because I had severe preeclampsia, which is why she was born so early. So there's also that. So there's those types of things can also restrict movement. Then there's hormones, all right? I mentioned the pubic symphysis, a hormone named relaxin can loosen that joint up before giving birth. And it loosens up during pregnancy too. So, you know, all of a sudden your hips have these weird movements. But there's also problems. There's people that have syndromes where they have hypermobility of their joints. And I've listed one here, Ehlers-Danlos syndrome in my notes. Really weak connective tissue can also affect that, all right? And then disuse, right? So, you know, as you get older, you don't move as much as you used to. So go figure, you're less flexible than you were when you were 3, right? And then also if you've had a cast on for like, you know, 2-3 months, if you had a really severe break, you know, you've got to go to some therapy to try and get your movement back. So all of these things, and oh, and a really cool thing, you know, astronauts, we don't really think about them when we talk about this, but there's a whole branch of physiology studying space medicine, looking at what's happening to the body, and you don't have as much strain on your joints, so that, you know, when astronauts come back, their joints are going to be, they have to, you know, I don't know if they go to therapy. I don't know any astronauts, but I'd imagine if you're in space long enough, you're going to have to go to therapy, or physical therapy, to, you know, bring back some of your abilities once you're in gravity. All right, so that's another little thing to think about. All right, so here, so range of motion determined by the structure of the articulating surfaces, the strength and tautness of the ligaments, the action of the muscles and tendons, right? So you've got a whole branch of the nervous system that's monitoring joint position, right? So your cerebellum is part of that. It's going to tell your brain where, you know, notify your brain, you know, where you're at, and keep your muscle tone. And then here's some examples, right? So I mentioned the pubic symphysis gets really loosey-goosey because of relaxin. This is actually a patient that has that syndrome I listed, where that Ehlers-Danlos syndrome, really crazy flexibility of the joints. This to me it freaks me out. My daughter, I think some people are double jointed. She can bend her fingers in weird positions. And then of course, you know, limited movement because of having a cast for an extended period. All right. Now the joint movements. So that's the other thing about synovial joints. All right. So they're also classified by the movements. And these are terms that you just have to learn, right? Just like your anatomical directions. And so I'm going to walk you through some of these. All right. So this is on my last page of my notes, I just list them. All right. So they're classified by different types of things. So gliding movements. All right. So simple back and forth, side to side movements. All right. And, you know, your intercarpal joints. All right. So limited, you know, but no significant alteration of the actual angle. All right. So that's something to think about. Then we have angular movements. And here we have an increase or decrease of the angle between the articulating bones. And we're going to throw out 11 terms for you, all right? So flexion is a decrease in the angle, and extension is an increase in the angle. And notice that these come in pairs. And in my notes, I sort of put brackets to highlight the pairs. So flexion is the opposite of extension, or extension is the opposite of flexion, depending on how you look at it. But you can also have hyperextension, where you could sort of continue the movement beyond a normal extension, all right? I have a picture to show you what that means. Then you have abduction, which is movement away from the midline, and then adduction is movement towards the midline, all right? And then, of course, circumduction, which is sort of a movement of the body in a circle, all right? So here are some examples. So flexion and extension, and here you can see hyperextension. You can hyperextend the shoulder, all right? So flexion, you're lowering the angle. Extension, you're increasing the ankle. And then hyperextension, you're going even further. Another way of doing it is around the waist, all right? You can also hyperextend that by leaning way back. Then abduction, and then adduction, right? So adduction towards the midline, abduction away from it, all right? And then circumduction, you know, you've got your ball and socket joints. That's where you can do circumduction. You can make sort of like a cone, if you would look at it with your leg or your arm. Then rotation, this is revolving around its own axis, all right? So then with that, you can have like your head turning nose, a rotation. You can have, you know, a medial rotation if you rotate towards the body, or lateral rotation away from the body. Okay, so that's the third classification is rotation. So medial, lateral rotations, all right? And then special movements, right? And you know, it's AMP. We need to confuse you even more. So special movements, part 1 of 3. Okay, so here you got a whole list, all right? And notice in my notes that a lot of them are in pairs, all right? So elevation is the upward movement of a body part, like closing the mouth. Depression is the downward movement of a body part, like opening the mouth. Protraction is the movement of a body part anteriorly, and retraction is moving it back into normal, right? And again, you can use the jaw as an example for this, all right? So here you can see it, elevation, depression, protraction, retraction. Because you know you can stick your chin out. I was just doing that. You could probably hear my voice more weird, all right? Part 2. Eversion is moving, this is particular the foot. Eversion, moving it laterally. Inversion, moving it medially. Dorsiflexion is bending of the foot ankle upward, okay? Sorry, that's my phone. I'm gonna have to deal with that later. Then we have plantar flexion is the bending of the foot and the ankle in the downward orientation. So dorsi is up and plantar is down, all right? So here you have your examples. So inversion and eversion, all right? So that's moving the foot side, you know, upward on the side direction, and dorsiflexion is up and down, right? So dorso up, plantar down, right? So if you're pointing your toe, it would be plantar flexion. Special movements 3, supination is movement of the forearm so that the palm is upward. Pronation, moving of the forearm so the palm is turned downward. Then we have opposition, all right? So movement of the opposable thumb. So this is a human thing. One of the things that makes us human, so oppositional movements, right? So you can hold a pen or a pencil. And here are your examples, all right? So posterior, so pronation and supination and opposition. All right, so here's your summary slide of all of those, okay? And again, there's all kinds of really cool YouTube videos of people doing this. I saw, this one was particularly fun. I saw a video when I was teaching at Dominican. I put this up for my students. A video where students were tasked with, you know, showing all these movements, and they did it to music, and it was really quite fun. So I'm sure if you look for videos on all of these, you can see all of them are really, really amazing. All right. Okay. Now, and then you're responsible for knowing some of the jaw, some of these joints, right? And there's 6 joints. And I've put together a series of materials here to help you sort of study these joints. And I really just want you to you know, use them and hopefully they'll help you and really sort of focus on the study guide to know what I'd expect for the test. I mean, there's so much to learn here. But basically, you know, first is the jaw joint. And what I want to stress here, and I didn't say this yet in this video, but a lot of the joints are named by the bones or the structural features of bones that are articulating, right? So here you see the temporomandibular joint. So it's between the temporal bone and the mandible, all right? And there's a lot of really cool features here. So you've got condylar surfaces, hinge and plane joints are all sort of combined in here. A weird thing here is that the synovial cavity has sort of 2 chambers with a disc in between, which you can see here, which is kind of unusual. And then there's the shoulder joint, and there's so much to learn there, right? You've got bursae, you've got tendons, and you've got ligaments all involved with this. So here you've got sort of your shallow glenoid cavity there. And there's names of fibrocartilage that's here. So there's a fibrocartilage ring that's here. So here it is right here. And you can see it sitting there. And again, remember these cartilages are there to sort of improve the shape of the surface. And then here, notice that your tendons are really helping in the functionality of this. And there's like capsules there to strengthen that, so that the tendon capsule that I was showing you before. Here are so many other features of this. I mean, what am I going to tell you? Just memorize all this? No, that would be crazy. I mean, unless you're going to become a doctor or a nurse or a PA working in orthopedic specialist, then you should learn all of this. But I really want you to just appreciate all of these amazing functions and structures that are here to hold these joints together and keep them functioning well. And then, like I said, use the study guide to sort of hone in on the particular features that I'd like you to know. I'll probably list a few. I haven't written that part of the exam yet, but it would be unreasonable for me to expect you to learn all of these things, all right? But have a look at this, appreciate what's going on here, and the complexity that there is here to allow for this movement to take place, all right? This is yet another slide of the same joint, right? So here you can see the ligaments that are actually running into the joints. You can see tendons that are outside of the joint. You can see the ligaments even between the different portions of the scapula that are also going to be here doing this. It's just absolutely amazing how this is all put together. And hopefully, I don't want you to lose sight of how amazing that is, all right? Then the elbow joint, again, look at this mass of tendons and ligaments here. Again, it would be insane for me to expect you to memorize all of these, all right? But again, look at how this thing is put together and how that, in all of the different, so here you've got a bursa here, and it would make sense. You've got a fluid-filled, pad here on the olecranon process to help protect that. And yet still, if you hit your elbow on stuff, it hurts like as we've all done it, right? And here, even more functions. If you look at the elbow, something functions as a pivot joint, some of the different parts there. And you saw that the pivot joint between the radius and the ulna there. But it's also involved in this whole joint, capsule, all right? And then, of course, the hip joint, again, really important for structure. Look at this thing. There's this round ligament that actually comes out of, and if you look on, if you see a femur where you still have the articular cartilage, you can actually see the space where this ligament comes out and joins in here. It's like this really incredible ligament that we have just to hold this in place. It makes me think almost of a marionette, right? With the cables there to hold it in place. Anyways, here a whole bunch of these things. And again, just pay attention to the study guide to know exactly which parts to learn, which will be on the test. And usually I try to pick them just so that you gain an appreciation of that. Because again, it would be insane for me to ask you to memorize all of these pieces and you'd lose sight of your anatomy. But again, look at all of these amazing structures that are here to help your thing. And then now for the knee joint, as you know, so much can go wrong there. This is where you really have these menisci between the tibia and the femur to really, help this. This one, if you're going to learn this one the most for lab. This is the one, and really focus on where I had arrows earlier in the presentation to make sure you know those parts, so the medial and lateral meniscus, the different ligaments, so the ACL. Make sure this is the one that I would, if you're going to memorize, this would be the one to memorize. And really get into this knee joint, and because this is the one that's traditionally used for teaching, and this is the one I'd really kind of like you to stress, but how much of these, really focus at least on those red arrows that I have back earlier in the presentation. Make sure you know those things, all right, when it comes to the knee joint. So here you have, even more information on that and what this is all for to help, orient yourself. This is cadaver section, so you can sort of see that. And then, of course, the ankle joint. Again, there's a whole slew of ligaments. You've got your medial and lateral malleoli of the tibia. Again, all kinds of different articulations that are taking place there, different tendons and ligaments. So you can see your Achilles tendon, right? And then you've got your multi-part, this is like a medial and lateral ligaments connecting this area as well. You know, lots of support. And again, here you can see by the image just how complex this joint is. And again, you know, just focus in on the study guide so you don't spend all your time just trying to memorize all of this. That's not the point. I mean, and I'm just showing you this because it was on the expectations or the learning outcomes for the course. All right. If this is something that you have a passion for, by all means, knock yourself out, right? But I'm going to sort of, like I said, pay attention to the study guide as to, you know, which features of which joints. And really what I would like you to sort of stress would be the knee joint, because that also overlaps well in lab. We don't have models of any of these other joints in lab, but the knee joint we do. So, and like I said, traditionally, having taught A&P at 6 different places, the knee joint is the one that's usually the focus, all right? So that would be my advice on how you should approach this part of this chapter. And again, it's kind of weird because it's really a lab thing, but that's what I would stress. And hopefully that helps. And again, if you have questions, let me know.